afternoon, everyone. I'm really glad again on a Friday afternoon. There are so many people joining for this course. And I think Dr. Nitya has already given a disclaimer. I'm a surgeon and I don't know much about oxygen delivery. And no, and I think there may be many people in the audience who have more experience than me and more knowledge. I'm fully aware of that. But what I've tried to do is try to simplify how oxygen can be managed in the wards. It's a very practical webinar. We're going to talk about that. But before that, a little bit of introduction about the various devices and all that I'll give. But mostly we'll focus on how to start oxygen for a patient, how to titrate the oxygen based on the doctor's orders, and how to wean a patient off oxygen. So these are practical things whom we discuss, and as surgeons, we are always interested in these practical aspects of care. So let me just start the webinar. I think a few people are raising their hands. Is there any problem? You can put in the comment or chat. I hope you are able to hear me and see my video. Okay, so we will answer questions or any doubts at the end of the lecture. Okay, so let me start the webinar. So in this webinar, we're going to talk, of course, about oxygen therapy. Who are the patients who require oxygen? And then we'll talk about type 1 and 2 respiratory failure and what is the target oxygenation we should achieve for these patients. Then we'll touch upon oxygen delivery devices. And as I told you, we'll look at a very practical approach to oxygen therapy and weaning oxygen off patients. So oxygen therapy is a medical treatment. You provide supplemental oxygen. All of us know that our atmosphere has about 21% oxygen and the rest is a mixture of other gases. But for normal adults, normal children, this 21% is more than enough. But when we become sick, then we need supplemental oxygen. So the treatment which gives the supplemental oxygen is oxygen therapy. And we can treat both acute and chronic conditions by supplemental oxygen. So what are the benefits of oxygen therapy in the acute setting? Like when the patient is really sick, it can be life-saving. It supports vital functions. And for the patient, when they come with breathlessness and you give them the oxygen, they feel very calm and relaxed because they're getting the oxygen they wanted. Basically, breathlessness is nothing but air hunger or oxygen hunger. So because of that, they are breathing more. And when we give supplemental oxygen, naturally the breathing rate comes down and it alleviates the symptoms of breathlessness. Now, we have to remember that oxygen is a drug, though it is available everywhere. And you can actually don't need to go to pharmacy and buy it. You just have to open it and you can give any patient oxygen. But it is a drug and it has to be carefully prescribed by the doctors and given only on the advice of the doctor by nurses and monitored carefully, because very low oxygen as well as excess oxygen can have very detrimental effects, dangerous effects on the body. So you need to use it with caution. Now, the second question I want to ask is, who are the patients who require oxygen? So the common clinical conditions we see in the hospital from whom we will give supplemental oxygen are those with acute requirements, short-term requirements. I will get into examples of that. One of the acute requirements is post-operative patients. Now, I see in my own field that every patient who has undergone anesthesia and therefore has got a loss of consciousness or they're just coming back to consciousness, after a surgery, they will require supplemental oxygen till they become fully conscious. So that is an acute short-term requirement. Then there are a lot of patients with chronic long-term requirements. Now, home oxygen therapy has become a big thing. Many of the hospital patients have oxygen concentrators at home, and therefore they also use these devices at home. So there are a lot of conditions, chronic conditions, where long-term oxygen therapy is required. Now let's see some examples of clinical condition. On the left is the acute clinical condition. You can see here pneumonia is the most common, lung infection, pulmonary edema due to cardiac failure, ARDS when patients become septic, acute attacks of asthma, trauma because of the rib fractures and all that. No, they require oxygen therapy. And then, as I already told you, post-operative recovery. These are some examples of short-term requirement. So once these conditions get treated, these patients will be okay with just the 21% of oxygen which is available in our atmosphere. Chronic clinical conditions, on the other hand, they need long-term. COPD is the commonest example of people who require long-term oxygen therapy, people with interstitial lung disease, pulmonary hypertension, chronic heart failure, and then neuromuscular diseases where the muscles are not strong enough for them to do the ventilatory function. For them also, long-term oxygen therapy is required. Now, we have to know about type 1 and type 2 respiratory failure. In my undergraduate days, I used to hate this, and some of the smart Alex of my class were very good at this. What is type 1, what is type 2, and what you do about it? And that's probably one of the reasons I took up surgery. But I think it's for oxygen therapy, it is very, very basic to need to understand what is type 1 and type 2 respiratory failure. It's very simple, actually. So let's look at the small table which will explain that. So type 1 is hypoxemic, meaning low oxygen levels, and people have normal carbon dioxide levels in the blood. So why do we need this differentiation is this target oxygen level is very important. So what is the target you want to reach when you're giving supplemental oxygen, before which we will wean them off, is the target oxygen level. And for type 1, when you're using the pulse oximeter, the oxygen saturation should be above 94%. Okay, whereas for type 2, which is known as also hypercapnic respiratory failure, hypercapnic means high carbon dioxide. So they also have low oxygen level, but their carbon dioxide retention is very high. So these people, you need to give a lower target of 88 to 92. This is according to the British Thoracic Society guidelines, BTS guidelines. I didn't make this up. Okay. So why does a type 2 respiratory failure patient need a low target oxygen level? This is a question which we need to understand so that we will be careful that we give them a lower oxygen so that they reach the target and not exceed the target. In a healthy person, whenever they need supplemental oxygen, breathing is maintained by the higher levels of carbon dioxide in the brain. So when we take in oxygen and breathe out carbon dioxide. So when this carbon dioxide gets retained in the blood and the carbon dioxide level goes up, this triggers the chemoreceptors in the brain and it sends signals to the respiratory system to become breathless and wash out the carbon dioxide. So this is the usual mechanism. So that's what is happening in a healthy person. But in people with type 2 respiratory failure, these are all people who have chronic respiratory conditions. The carbon dioxide level has been increased for a long time. So the central drive to stimulate the respiration is dampened. So they are actually surviving because the low oxygen level is stimulating the peripheral chemoreceptors. In the carotids, these are known as the peripheral chemoreceptors. So they are sensitive to low oxygen. So the low oxygen then tells the brain that there is something wrong, and this drives the respiration for them. So the low oxygen, that is the low saturation of 88 to 92, is very necessary for them to breathe normally. So if you enthusiastically treat this patient and bring them up to 94, 98, then what happens? That hypoxic drive is suppressed and the respiration also will get depressed and they actually become worse. So that is the reason type 2 respiratory failure patients have to be maintained on a low target oxygen level between 88 to 92, whereas normal people with type 1 respiratory failure, they can have a saturation level of above 94 up to 98, 99, no problem will happen. I hope I made this clear. So this is the reason why type 2 respiratory failure has got a low target oxygen saturation levels. Now, examples of type 1 respiratory failure, or mostly you will see, are acute pneumonia, pulmonary edema, ARDS, pulmonary embolism. But there are also certain conditions like interstitial lung disease, which are also classified under the type 1 respiratory failure, because here the alveolar membrane becomes thick and therefore there is not enough transfer of oxygen. So it is basically ventilation perfusion mismatch which causes type 1 respiratory failure. Now, what is type 2 respiratory failure? These are, as I said, hypercapnic. The most common example is the chronic obstructive pulmonary disease, COPD. Severe asthma can also be there. Obesity, hyperventilation syndrome, neuromuscular disorders like amyotrophic lateral sclerosis, muscular dystrophy, sleep apnea. So these people have chronic carbon dioxide retention. And that's why the hypoxic drive is very, very important. So with that out of the way, we now know about type 1 and type 2 respiratory failure and what are the target to achieve in these classification of patients. Now, the most common device which is used to monitor patients who are on oxygen treatment, supplemental oxygen, is the pulse oximeter. I'm not going to go into details of how this works. Basically, it estimates the percentage of hemoglobin molecules in the arterial blood that are saturated with oxygen, and it is measured non-invasively. Not just you have to put them on the finger, very, very convenient, and we can do this. So that is known as the saturation pulse oximeter, which is the blood oxygen saturation levels. It's in short known as SpO2. There is also another level which is used in the ICU. It's known as the partial pressure of oxygen in the blood, PaO2. And this measures the amount of oxygen gas dissolved in the blood. This is much more precise. No, that is only a proxy measurement of your oxygenation saturation levels used by pulse oximeter. Here you do an ABG, arterial blood gas analysis, and it is a direct measurement of what is the oxygen that is dissolved in the blood. But this is mostly used in the intensive care settings, and so I'm not going to talk more about it, because in this lecture is more about managing patients in the day-to-day wards. So with that, we will get into the oxygen delivery devices. So there are oxygen has to be delivered through some device, right? So these are known as oxygen delivery devices. In a previous webinar, we talked about the various oxygen banks and how it is brought to the wards and what is the flow meter and all these things. Now we had actually a podcast on this with Mr. Vinod. I hope you remember that. Otherwise, you can go to the YouTube and watch that. Here you are focusing on the oxygen delivery device. And these devices, we have to choose based on the oxygen needs of the patient and the severity of the condition. So this is very important to know which device to choose for what patient. So we classify this very broadly into low flow devices and high flow devices. Low flow devices is low flow of oxygen. High flow is high flow, which is the how many liters per minute are you is flowing through these devices. So that is the flow, which can be set in the flow meter on the wall. So the low flow devices are nasal cannula, simple face mask. Now this non-breathing mask is like, it will be here and there. So actually non-breather mask is actually high flow device, but some of them classify into low flow. In this lecture, here I put it in low flow, but later I will discuss it as a high flow. But actually, according to, again, British Thoracic Society guidelines, non-rebreather mask is a high flow device. Now, high flow device is the most common, which is used in every hospital, is the Venturi, otherwise known as the fixed performance mask, then the high flow nasal cannula, and then the CPAP, BiPAP, and of course the ventilator. Okay, so these are all non-invasive and invasive ventilation. Again, I'm not going to touch upon this in this webinar. We're going to restrict ourselves how to manage a patient in the wards using low flow and high flow devices, basically the Venturi and the HFNC. Okay, so the next question which I asked is humidification of oxygen necessary? It is not necessary for short-term use. If you are using just for a few hours, so mostly in ambulances, it is not necessary to humidify oxygen. But all inpatients who are going to stay for more than 24 hours, it is a must to humidify the oxygen. This again is the guideline, which is you have to know. Now, what we have to understand, we'll first talk about low flow devices. What we have to understand about low flow device, this is an approximate device. Okay, it gives supplemental oxygen, but at a rate that does not fully meet the inspiratory needs of the patient. So if you want precise oxygen delivery, then you should not use low flow devices. But for most patients, when you initiate oxygen, this low flow device is enough. And why these are not that reliable is because of these variables. When you use the low flow device, these things, the patient's breathing pattern, whether he is shallow breathing or deep breathing, or is breathing fast or slow, will alter the FiO2 given to the patient. No fraction of inspired oxygen given to the patient. Similarly, the tidal volume is another variable, and the device used is also another variable. So it may not fully meet their inspiratory needs. This is something you have to keep in mind when you use low flow devices. Now, the nasal cannula is the device which is used most commonly. We start with nasal cannula. It gives 24 to 40% of inspired oxygen. What is the efficiency? As I said, they are not that reliable. So the efficiency is low to moderate. And the most important variable is the patient's breathing pattern. So that is for the nasal cannula, because it just sits there. There's a lot of leak of oxygen outside into the atmosphere. The patient also breathes some amount of atmospheric air. Simple face mask gives a little bit higher FiO2 because the mask can be fitted a little bit more snugly onto the face. So here it gives 35 to 50% of FiO2. Again, the efficiency is low to moderate because there is significant mixing of room air when you use a mask. Whereas if you look at high flow devices, these are non-invasive devices which can deliver both humidified, warmed oxygen to the patients. And it is used for patients who require oxygen requirement is very high. So if you look at the high flow devices, again, the workhorse is the Venturi mask. Here the range is very, very accurately you can set depending on the color of the Venturi you are using. It ranges from 24 to 60. Again, I'm not going to go into details as which color Venturi is which and all that, because here we are talking about how to start oxygen, how to titrate the oxygen, how to wean off the oxygen. I am sure all of you are very well aware of that. And even if you're not aware, if you look at the Venturi device, green, it will be there, 24. And what is the flow you have to set on the flow meter also will be printed in that. So here, as I said, the efficiency is very high. Precise control, if you put that green, it will give only 24. So that is how precise it is. So as I said, I have moved the non-breather from low flow to high flow here because that is what BTS says, British Thoracic Society Guideline says. Here, as you can see, it is much more reliable. I mean, not reliable. It gives much more higher FiO2, up to 90% FiO2 it can give, depending upon how nicely you fit the mask. And the efficiency is actually not as much as Venturi mask, moderate to high, and there is minimal air mixture. However snugly you fit, there will be some admixture of air in this. High flow nasal cannula is, you can give up to 100% FiO2 and up to 60 to 70 liters of flow. And it gives a very high efficiency, precise oxygen, humidification, warming, everything can be done with the high flow nasal cannula. And more importantly, you don't put a mask or anything, and you just put a nasal prong, so it is much easier for patients. They can still eat and all those things. So high flow nasal cannula actually came to the fore during COVID because people were afraid to ventilate patients, and that's when it came to the fore, and it was proven that it reduces the oxygen and ventilatory requirement, and it also reduces the mortality. So high flow nasal cannula are very good devices if you want precise control. Now, the last part of my webinar is about a practical approach to oxygen therapy. As I said, there are only three things. You should know when to start oxygen, and when a patient on oxygen, how to titrate the oxygen supply up and down, and when you have to discontinue the oxygen, which is known as weaning the patient of oxygen. So let's look at it one by one. So before starting the oxygen treatment, because of the difference in the target, you have to ask the question, is this patient having type 2 respiratory failure? If you're a nurse, you have to make sure with the doctor. And if you're a junior doctor also, you ask your consultant, is this patient having type 2 respiratory failure? Now, if the answer is yes, then you know the target is 88 to 92% saturation. But because these people need much more stricter control of the oxygen, because you go high, the respiration will be depressed. You go low, they'll become worse. They become sicker much quicker. You will use saturation, but you will also use ABG along with your pulse oximeter to monitor these patients. And you will straight away start them with the Venturi of 24 to 28%. And you will use ABGs typically to monitor this patient and titrate the oxygen levels. If the answer is no, then they have type 1 respiratory failure. Here, your saturation should be 95 and above. And you can start them with nasal prongs and again titrate up and down. And you can, most of the time, monitor them with a pulse oximeter unless the requirement keeps going higher and higher, where you have to shift them to the ICU. Then you have to use the ABG or arterial blood gas. Okay, so these are the indications to start the oxygen therapy. Now, oxygen is a drug, as I told you, it has to be prescribed. So most hospitals, it's still a verbal order, but in your drug chart, there should be a section where oxygen should be there and oxygen should be prescribed. So when you prescribe the oxygen, prescribe the target range, because type 1 or type 2, okay? So is it 94 and above or 88 to 92? That is more important for the person who's actually administering oxygen at the bedside, the nurses. They are not interested in FiO2, PO2 and all those things. That is the doctor's job. They'll be looking at the pulse oximeter and titrating the oxygen up and down. So prescribe the target range, what device you wanted to use, and how many liters you want to put, that will be decided by the nurse depending on the device. Okay, so just prescribe the target. And I agree that in most emergencies, oxygen is given as a verbal order. It is acceptable in emergencies. But routinely in the wards, it should be prescribed in the drug chart. That's something which I wanted to emphasize here. Now, this is again, I sort of copied and pasted the British Thoracic guidelines here because it could not be improved upon. Okay, so you will start with the nasal cannula 1 liter or 2 liter. This I'm talking about type 1 respiratory failure. And depending on the need, you'll go up and down. Okay, you give 2 liters, you reach the target, fine. See for some time, you try to come down or you discontinue the oxygen. If they become hypoxic, you go up. But if you're gradually going to 4 liters per minute and you're reaching around 5 liters, it is time that you went into a high flow device. And this is the time also for nurses, you should seek the doctor's advice or for junior doctors to seek the consultant's advice. Okay, so because however much for flow you're going to increase on the flow meter, the nasal cannula or mask will not actually give more oxygen because as we know already, they are not that reliable. Okay, so when it reaches 4 liters, you have to keep dialing the flow meter, 4 liters. You've got to think whether this patient needs Venturi. That is the blue, which is 24%. Okay, so now you can also try to use simple face mask because as we saw, simple face mask gives more FiO2 than a cannula. Okay, so but if you're using simple face mask, you may have to go directly to a very higher level of Venturi. So once you start the now around 4 liters, you probably will start in yellow, 35. Then you will dial it up and down. So, if the patient is requiring more, you will use the Venturi 40% and then you'll go to Venturi 60%. If still the patient is hypoxic, definitely patient has to get shifted to the ICU or IMCU and go into one of the non-invasive ventilation or high flow nasal cannula. On the other hand, if you're able to dial down, you come slowly down to the lower Venturis, 35, 28, 24. And once you reach 24, you can, put them back on nasal cannula. So this is how you will titrate, and you will, along with the saturation, you will also look at these signs of respiratory deterioration. Increase respiratory rate more than 30, decrease saturation, we already told you, and greater need for oxygen. So you keep on increasing the flow means you're giving more oxygen. So these are all danger signs, red signals that you should probably either move up or move to a high flow device. And you should also know that these are the reasons where you'll ask for seniors or doctor's advice. Okay, so this is how you titrate. Basically, in the wards, it is done using the nasal cannula and a face mask and the venturi. And you go up and down based on the saturation level and the signs of respiratory distress. Okay, so this is the how you titrate oxygen. Now, how do you wean off? How do you know when to stop the oxygen? So here we'll go step by step. I will take off the laser pointer, or maybe still there. Okay, so the first question to ask is, you'll have to ask some periodic questions. These questions are very important. So is the patient clinically stable with oxygen saturation above target for 4 to 8 hours? We know for type 1 it is greater than 94, type 2 it is 88 to 92. If it is now in the target or above target, then for last 4 days, 4 hours or 8 hours, then if the answer is no, then you monitor and maintain the current settings. That means the patient is not ready for weaning off. On the other hand, if the answer is yes, then you can lower the oxygen concentration. How to lower the oxygen concentration? We just discussed in the how to titrate. Okay. So now the next question to ask is, once you lower, suppose from venturi you come from 60 to lower level, then you come to 24. You have to ask, is the target saturation maintained? If it is not maintained, you have to adjust the oxygen levels and keep readjusting. Okay. On the other hand, if the oxygen saturation is maintained, you further reduce it. And then if you're now coming to the nasal prongs 2 liters per minute, then the next question you have to ask is the target oxygen maintained for at least 2 observations? Your doctor might have told second hourly or fourth hourly, whatever the observation which has been asked for the patient. 2 observations you see, and still with this low oxygen level, they are maintaining the concentration. Then if it is not happening, then again you have to adjust the oxygen levels, keep doing this till you reach this level. Once the target oxygen is being maintained for 2 observations, then you can stop the oxygen. And when you stop the oxygen, you put the pulse oximeter and monitor it continuously for 5 minutes. If it is still normal, you discontinue it and then go back after 1 hour and recheck it and see if the patient is able to maintain oxygenation at target level on room air. If that happens, then the next question is the oxygen sat and clinical condition stable without the oxygen and for 5 minutes initially and then after 1 hour? If the answer is no, you continue monitoring, go back to giving them oxygen, adjust oxygen levels, and then go through the cycle again. Meanwhile, you'll be treating them for whatever condition they came with to the hospital. On the other hand, if the patient is stable and clinical conditions also stable, no signs of breathlessness, no signs of respiratory distress, then patient can be safely discontinued from oxygen therapy. So this is how you wean off a patient from oxygen. A simple algorithm that anyone can follow. So with that, we come to this end of this webinar. So we talked about oxygen therapy. What are the introduction? What is oxygen therapy? Sorry, and what are the benefits? And then we spoke about indications, acute conditions, chronic conditions, post-operative conditions. And then we talked about the 2 types of respiratory failure, type 1, type 2. Why should we know about this? It's because the target ranges are different. For type 1 respiratory failure, where there is hypoxemia but not high CO2 in the blood, it is 94. Whereas type 2, where there is high CO2 levels, in addition to hypoxemia, you don't want to reduce the hypoxic drive, and therefore you keep the saturation low at 88 to 92%. Then we spoke about low flow, high flow, and non-invasive ways of ventilating the patient. And of course, I didn't talk at all about the invasive ways of ventilation. That is for the specialists to talk about. And then we looked at the practical approach of how to prescribe and how to titrate, how to start a patient, when to start a patient on oxygen, and finally, when to wean the patient, and a simple algorithm that can help you to wean off, and the questions to be asked at various stages while you're going to wean the patient of oxygen. Thank you so much for all of you. I think it is really a learning experience for me giving this webinar, and I hope all of you enjoyed it. Thank you so much.